Today, we're going to welcome a couple of familiar figures from our community here. Dr. Emily Forbes, a fellowship-trained movement disorders neurologist at the University of Colorado Anschutz Medical Campus, and Dr. Megan Salinas, medical director of the Rocky Mountain Movement Disorder Center. Dr. Forbes and Dr. Salinas are also the directors of the HDSA Centers of Excellence at their respective organizations. And we will arguably and potentially very biasedly, most excitingly today, be speaking a little bit about HD research and promising new therapies. So to get us started, please welcome Dr. Forbes.
Perfect. Can you hear me? Okay, I think it's working. So I am really honored to be able to talk to you today about breakthroughs in Huntington's disease and HD research. An outline of our talk today is I'm going to do a quick genetics refresher. Then I'm going to talk about the positive results from the AMT-130 study. So I think a lot of you have probably heard about this or seen this. So we're going to go over all that data. And then we're going to talk about a few other potential therapies and research, including antisense oligonucleotides and what's recently been called Votoplam, which is an oral treatment that's about to enter a phase 3 study. So, quick refresher, Genetics 101. We all have a complete set of all of our DNA in each of our cells. And our DNA essentially is a blueprint for making the proteins that the cell needs to function. As you might imagine, even though we all have a complete copy in all of our cells, our liver cells are using different proteins than our heart cells and different proteins from our brain cells. And the way it works is all of this DNA is wound up tightly in the nucleus of our cell. And when our cell needs a gene, it calls up that DNA. So you can see that on the left. So it calls up that DNA, it gets a copy of the gene that it needs, and it turns it into a messenger. And that messenger is RNA. That's the strand in the middle. The RNA goes out to where all the machinery that turns this into a protein is, so it goes out into the cytoplasm, and that message becomes a protein. And the goal of many of these therapies is to prevent this step from happening. We don't want this message turned into a protein. All right, so the genetics of HD, I know a lot of you are familiar with this, but we're just going to go over it briefly. So this is a CAG repeat expansion. And so individuals who have less than 35 repeats, that DNA message goes on to make a normal-sized Huntington protein. And then that protein goes on to function in a normal, healthy neuron. Individuals who have too many of these CAG repeats, so if it gets above 35, that goes to make an elongated protein. And so this mutated Huntington protein or elongated protein is toxic to our cells. It wreaks havoc in our nerve cells, in our neurons, and it essentially, that long repeat in there, it makes it kind of a sticky protein, and then they all stick together and they aggregate in the cell. And it stops the neuron from functioning normally. And when the neuron goes through that, it recognizes that it's not functioning normally and it gives itself a signal to die off. And if this was one individual neuron, it would not be a problem. The problem is this is happening on a mass scale in our brains because this protein is required in so many of their brain cells. And so if we look at the brain and we take a cut, and so this image is if you take a cut through the brain like this and look at it straight on, there's an area called the striatum. So this area is affected first and foremost in HD. And so on the image on the right, you can see the normal and mutant protein, and on the bottom, that aggregation of toxic fragments of mutant protein that leads to cellular death. And this happens really pretty aggressively in that striatum, and that's a pretty deep part of the brain. So we're going to go back and just look at where we can target that prevents that protein from being made. So this is a little bit more of a busy picture, but it essentially shows you something similar to a couple of slides ago where we're in the nucleus of a cell and we have that green strand, which is our DNA. That DNA gets turned into that messenger RNA. There are some therapies out there and some research out there that you can see in those pink squares, CRISPR and ZFP, which stands for zinc finger protein. Those are preclinical, meaning they're looking at them in the lab and they look very promising. We're not going to really get into those today, but there is work being done on the DNA itself. We are looking more at this messenger RNA. And so this messenger RNA with the abnormal expanding CAG repeat gets made. It goes out into the cytosol and it gets turned into a protein. And this is really what we want to prevent. And we're going to talk about 3 different strategies today. The first, we're going to talk about how we can use what's called an AAV, or a viral vector, to prevent that protein from being made. Then we're going to talk about something called ASOs, or antisense oligonucleotides. And then we're going to talk about small molecules. Okay, so let's move forward and talk about the positive results of gene therapy in HD. So I woke up on September 24th, as I'm sure everyone here did, to this headline that uniQure has announced positive top-line results from a pivotal phase 1/2 study of AMT-130 in people with Huntington's disease. And this is one of the many headlines that was sent to me and that came up on my phone. Before we start looking at these results, which are really extraordinary and we're really excited about, I want to remind everyone, this is an investigational medicinal product. It is not FDA approved as of today, October 18th, 2025. This is not approved by the FDA. It is not approved in Europe. It is positive results from a clinical research study. So I also want to mention this phase 1/2. So what does this mean? And why was it so important to add in the announcement? So there are different phases of clinical trials. We have the preclinical and discovery times where this is essentially in a lab. We're looking at human cells or mouse models or non-human primates to see if there's any sort of compound that can help treat a disease. And if something looks promising, it then goes into the phase 1 study. And phase 1 is all about safety. We give it to a few people, make sure that it is safe and well tolerated. If that looks good, then it can move on to a phase 2 trial, which is when more people are exposed. And again, safety is paramount. It's the first thing that we're looking for, but also any hint of efficacy, or does it work? And if that looks good, it typically goes on to a phase 3 clinical trial, which is when we give it to many people. This is in the hundreds, or in some cases, even thousands of people can receive a study drug. And if that looks safe and it looks like it works, that is typically when a company will ask the FDA to review that data and approve a medication. This is a phase 1/2 trial, so it is looking at earlier data than a typical clinical pipeline because there's such a desperate need in Huntington's disease, and the company feels like their data looks really good. Okay, gene therapy. So we're going to talk a little bit about this. This is a technique that uses genetic material to treat or prevent a disease. So AMT-130. So this is a one-time administration of an investigational medicinal product that potentially has very long-term results. It is delivered directly into the deep brain. And so you can see that on the image on the right. So this is well within the brain, that picture of the striatum that I showed you before, that's a deep part. So this is where this is going. And it has 3 sites on one side and then 3 sites on the other side. The treatment suppresses both the normal gene expression and the abnormal gene expression, because remember, in someone with HD, they have one elongated CAG repeat, and that goes to make a prolonged protein, but they still have one that's normal, typically. The goals of this study are to slow the progression of Huntington's and improve quality of life. So who was in this study? So you can see there are 2 groups of people. In the orange, there's the high-dose group, and in the purple is the low-dose group. We're mainly talking about the high-dose group results today. And so you can see there's a timeline on top, 12 months, 24 months, 36 months. This is the course of the study. So this is how long that they have data for. And you can see high-dose AMT-130 arm, and there's parentheses n equals 17. That means 17 people got this dose. Now, right below it in the gray box, you can see Enroll HD matched external control arm and then N940. What that means is they did not have an internal placebo control in this study. People who got this treatment were compared to individuals from the Enroll HD cohort, and they tried to pair them so they looked similar to the individuals who enrolled. And so this is important to note because most studies do have a placebo control, especially when trying a new investigational product. As you can imagine, It would be very hard to convince people to go through a prolonged neurosurgery with holes drilled into their brain or into their skull and a cannula advanced in their brain with an infusion if there's a chance they could get the placebo. And so there was no placebo control. I will mention, in case anyone has gone through some of this, which has been advertised online or posted online, in the United States, because this trial went on in the United States and in Europe, in the United States, there were 10 people who did get a sham surgery early on, but they were only allowed to basically not know that they got the sham surgery for 1 year. And after 1 year, they were told whether they got the sham surgery or not, because they thought, essentially the FDA said it's unethical to keep people in a blinded group like this for a clinical trial like this. So there were 10 very brave people who underwent a sham surgery. All right, so all the way on the right, you can see N equals 12 patients with 36 months of follow-up as of June 30th, 2025. That means of the 17 people who got the AMT-130, the high dose, 12 people had data or finished at the 36-month mark. So they got up to 36 months, and they analyzed those people. When we have clinical trials, especially ones that are involved in this, it can be very difficult to recruit and have people enroll. And so not everyone enrolls at the same time. It could take years to get enough people for a trial like this. And then right under it, you see the propensity score matched AMT-130 high dose arm. Propensity score matching is a statistical technique that allows us to compare two groups if one is from the enroll cohort and one is from a cohort that is getting the therapy. And so what it essentially means is we want to compare similar people. We don't want to compare someone who's like a young marathon runner to somebody who's older and has heart disease and hypertension and high cholesterol and all these other things. That's not really a fair match. We want to compare apples to apples. And so they use this method to ensure that they're getting people who are well matched. And so this just gives you an idea of ways that they matched. And so the top three are pretty clear. So sex, age, and CAG repeats look similar in the group that got the AMT-130 and the historical controls. And then they looked at a whole slew of other measures that they wanted to make sure that people were similar on going in. Okay. Then they looked at how do we measure results, essentially. So in clinical trials, we really like to have a single outcome that captures disease across multiple domains. So as we know, Huntington's is not just one thing. We have motor symptoms, we have cognitive symptoms, we have changes in function. And so instead of looking at each of those individually, we like to have one composite score that captures all of these. So for that was the composite Unified Huntington's Disease Rating Scale. So this is the first thing they looked at. And this is a composite of the total functional capacity. On the left, you can see this is impairments in occupation, finance, domestic chores, daily living, and care level. So that was part of the composite score. They looked at the total motor score, which is impairment in motor function. They looked at symbol digit modalities tests. So this is one of two cognitive tests, essentially a thinking and memory test. And it looks at attention, processing speed, and working memory. They used a second thinking and memory test called the Stroop word reading test, and that measures selective attention capacity and processing speed. So these were all things that went into the composite score. So now I'm going to show you the first piece of data that was released, which is the composite UHDRS. So the company has said that they have seen a 75% decreased progression or reduced progression based on this data point. So what does this mean? Okay, so you can see on this graph, what we know is down is worse. And then on this horizontal line, it's essentially time. So we have a baseline, 1 year, 2 years, and 3 years. The gray line is the historical controls. Those are people from Enroll HD. And you can see that over the course of several years, they progress. They get worse year after year. Then, if we look at the orange line, which are people treated with AMT-130, we see it also goes down, but there's a clear difference here in how much it goes down. And so this difference, here we see individuals in the Enroll HD cohort went down by about 1.5 points. People who had AMT-130 went down by about 0.38. So that is where that 75% slowing is. One thing to note, this does not appear to stop the progression, and it doesn't appear to reverse any damage that has already been done. So that's important to know. But it does seem, based on this data, that with the composite unified Huntington's disease rating scale, it slows the progression. Again, only 12 people, so very small sample size. And these lines, essentially, you can see there's a line around each. These lines are the probability that the true point is somewhere in between here. So this is what we think. It's hard to have an exact point. You'll see these lines are smaller, again, because they have 568 people that they were looking at. So they had a lot more data, and these lines are larger because we only had 12 people. All right. So the next thing I'm going to talk about is the total functional capacity. So this is something that we measure in clinic. It essentially looks at ability to perform normal occupation, ability to do finances normally, ability to do your own activities of daily living, domestic chores, and if you're able to receive care at home, or if you need help at home or need to go to an institution. So this is part of that composite unified Huntington's disease rating scale. But if we look at it on its own, we also see a difference. So remember, down is worse, and then horizontal is over time. And we see, if we look at the historical enroll cohort, that gray line, those people get worse more than people who got AMT 130. And then I know some of you are thinking, doesn't it look like that line goes up a little bit? It does, but remember, there are only 12 people in this data point. And so somewhere between here is probably where that true data point lies. And we see that there's a difference between where those two lines end. So it looks like there's a slowing, but we can't say much about, is it actually getting better, or is it just within the margin of error here? And so when they say that AMT 130 reduced the progression of HD by 60% based on the TFC, that's what they mean. It's this difference. Okay, the next thing they looked at was that first cognitive test, the symbol digit modalities test, which looked at attention, processing speed, and working memory. So this one, I don't have a by year time point for you. We just have this bar graph, but we can see, again, down is worse. Historical controls got worse more than individuals who got the AMT 130 high dose. They say this is reduced. So this reduction by 88%, this is what that means. That's the difference here. They also say, they also say at 36 months, and you might see this p.057. So a p-value is basically our confidence that something is a true result. We want to make sure this is real and not just by chance. And so we want those p-values to be very low. The lower it is, the less likelihood it is by chance. They tend to be higher, again, in smaller groups. So if we only look at 12 people, this might be a larger p-value, so more likely that it's by chance. So essentially, it needs to look at more people and see how this pans out. And the second cognitive test that they did was the Shoup word reading test, which looks at attention capacity and processing speed. And again here, individuals in the gray were the Enroll HD cohorts. So these people get worse over the course of 3 years. Individuals in orange were people who got AMT 130. Again, I know what you're thinking. It looks like it's actually going up. Again, it's hard to tell from this data, but certainly these are exciting results. All right, and then the last one, the motor score. So then they looked at motor score, and they kind of went through it in the way that I presented it, where they looked at the composite unified Huntington's, and if that was positive, they looked at the next thing and the next thing. I think we all would agree that if Huntington's disease was solely a disease of motor change and no other symptoms, it would be a whole different thing. But the motor symptoms are really important to treat, and they can be very quality of life limiting for people. They see that, we switched it up a little bit for you. In this slide, higher up is actually worsening. So if it looks like everything's going up, it is because that's what's worsening in the way this data is displayed. So people in gray were part of the Enroll, the historical controls. They got worse, and individuals who got the AMT 130 got worse. This was not statistically significant. So we see that p-value down there. So there's kind of a higher chance that this data fell like this just by chance. Essentially, the way to get more data on this is just look at more people and see how it pans out. Okay, now I'm going to mention something that we don't talk about that much in clinic, but is certainly used in research a lot. So this is the natural history data that shows NFL. So NFL here, it's not the Broncos, it's neurofilament light chain. So this is a marker of neuronal stress. So we know even in individuals who are healthy, this goes up as we get older. It goes up a little bit. In Huntington's disease, this goes up a lot. So it goes up more in Huntington's disease. I want to mention, this is not specific to Huntington's. This is a general marker of stress on our brains. People who have Alzheimer's will have elevated levels of NFL. People who have MS, or even people who've had brain surgery for other reasons, their neurons will put out this distress marker. So this increases in HD by about 10 to 15% per year. So we see that it gets worse in HD, and it's a marker of stress in our brains. In people who got AMT 130, they actually had reductions in this neurofilament light chain at 36 months. So this slide's a little different because what I'm showing you here is those people who got the high dose AMT 130. This is what we've been looking at the whole time. Also people who got low dose. We haven't really talked a lot about the low dose. The data is more interesting for the high dose, but they did put this out just so people can see. The control here is the baseline of these individuals. So they looked at them before they got the AMT 130 and then at 3 years. And we see that in both groups, this decreased. So that is very promising. All right, and then they have a whole large matrix and chart of adverse events or adverse effects. So whenever somebody's in a clinical trial, we keep a very close eye on any adverse effects that might happen. And so what we see here is headache, procedural headache, procedural pain, post-lumbar puncture syndrome, procedural complication. A lot of these adverse effects have to do with the actual procedure of getting the therapy or the lumbar punctures that are required as a part of clinical research. People also reported anxiety, constipation, insomnia, back pain. I don't know if anyone here has participated in a clinical trial. If you have, big thanks to you. I think you know that when you're in a clinical trial, we like to know everything that's going on. If you were visiting family and your cousins had a cold and then you had a cold, we want to know about that cold. If you twisted your ankle, we want to know about that. Everything gets recorded. And so this is a part of that. All right. So went through the good news. Now comes a little bit more difficult news is how is AMT 130 delivered? So I mentioned this before. This is a gene therapy delivered directly into the striatum with the goal of slowing disease progression by interfering with the production of that toxic Huntington protein. It is delivered once via neurosurgical procedure. I think there were some things here. Okay. What are they actually delivering? So there are two components of this treatment. So the first is a viral vector. It's an adeno-associated virus. So essentially, we live in a world where there are millions of viruses out there. Some of them affect us, many of them do not. So AAV is one that's thought that does not affect humans. It does not cause problems in people. Viruses are able to infect us because they use these spikes on their outer shell to trick our cells into letting them in. And then an active virus will then go in and hijack our cell's own machinery to make more viruses and essentially just produce more viruses. And that's why we get sick from viruses that do affect us. But scientists have developed a way to essentially program a harmless virus, like this one, to use our cell's machinery to make a therapeutic medication. And so essentially what they do is they take this virus and they keep that shell so that it can get into the cell. But instead of having viral particles in there, they take those viral machinery and viral instructions out. And instead, they put in a piece of genetic material that they want. So this is a microRNA. It's a small piece of genetic material that can prevent the production of an abnormal Huntington protein. So they put those instructions in a virus. They send it in. It is able to get into the neuron or the brain cell and then go on and produce this helpful treatment. Once the neuron has been treated, it can, in theory, continuously make its own Huntington-lowering molecule, and this should result in reduced production of the Huntington protein. The goal here is a very long duration, potentially even for life. We only have data on 3 years because the study has only gone out to 36 months. So we don't actually know how long the treatment duration is, but it potentially could be very long. Okay, so some immediate questions that I'm sure a lot of people here have, that I have. Will this be approved? So this is going up for FDA approval in the first quarter of 2026. And so we're just going to have to wait and see what happens with that. It's possible that the FDA will say, we'll approve it, but for only some people. They have to meet certain conditions or be in a certain phase of disease. It's possible they have some other comments on it. It's possible they ask the company to do something else or more data. So we'll just have to wait and see. So the next is who will be eligible for this treatment. We'll know more about that if the FDA approves it. We'll get that guidance. The question is, should we treat people who are pre-symptomatic and have no symptoms that they can detect? We don't know. We'll just have to wait. I wish I could answer that for you today because I'm sure that's a very pressing question for everyone here. Where will this treatment be delivered? So as you can imagine, this is not something you can go into like your PCP or local neurologist and pick up. This is pretty involved. So we think this is going to be done at big centers that already have neurosurgery capacity and the ability to deliver this. And so there will probably be specific centers around the country. Here, we are already talking with our neurosurgeons about a path forward for this in case it does get approved. And I'm sure many HD centers around the country are doing the same. And then, will this be covered by insurance? So a treatment like this will likely be cost prohibitive for almost anyone if insurance doesn't pay for it. And so we'll see what the FDA says, but once that announcement is made, we'll know more about the insurance coverage. Okay, so let's talk about next gene therapy, ASOs. And so remember, this is kind of our scheme. We have our DNA all the way on the left in green. It gets turned into a messenger and sent out to become a protein. We want to prevent that protein from being made. And so we're going to focus on ASOs. What is this? This is an antisense oligonucleotide. What does that mean? Well, our DNA in the nucleus over there on the left is pretty safe. It's blocked off from the rest of the cell, and it can just sit there for our entire lives. And when a piece or when a protein is needed, so say our neurons, our brain cells, need a specific protein, it will call on that DNA to find the specific instructions for the protein, and it will make a copy of it and send it out. So that's the mRNA. So once that messenger RNA, the blue line, gets out into the area of the cell where there's the machinery to make a protein, it's pretty vulnerable. It is a good place to target it. And in fact, there's something called an ASO, antisense oligonucleotide. That is a little piece of nucleic acid that is complementary and binds. And when this binds, your cell knows that this is not normal. And its response is to destroy it before it ever becomes a protein. And so that's how it prevents certain types of messenger RNAs from becoming proteins. This strategy has worked successfully in other neurologic conditions, and they're looking at it in HD. Now, after the first research study, you might wonder, how does this one get into the brain? So this one's a little bit more accessible. So this is like a lumbar puncture, if anyone's had a lumbar puncture, where they go into the lower back and they put a needle and they advance it into the area where there's cerebrospinal fluid. That's the fluid that coats our brain and our spinal cord, and that's within the central nervous system. So unlike a lumbar punctures pull fluid out. This would push in a therapy, and that's how this accesses the brain. So this is the Generation HD2 study of tominersen. This was a phase 2 study of placebo, or this is a phase 2 study of placebo versus 60 milligram versus 100 milligram dose of this ASO. Individuals who are enrolled are 25 to 50, and with prodromal or early HD, meaning they have HD that are just the very first hint or first signs of symptoms. The goals of this study are to understand the side effects of this medication and its administration, look at changes in the amount of mutant Huntington protein in spinal fluid, any changes in MRI brain scans, and changes in function. So, for example, ability to think, move, perform daily activities. And so there were updates in April. So April 2025, the company released some updates They had an independent data monitoring committee. So whenever these clinical trials go on, they have just a separate group, an independent group that's not really involved in the company. They look at safety data, and they found no safety concerns. So that was great. The trial now focuses on the 100 milligram dose. So they suggested everyone who was getting it just get the 100 milligram dose. This was because of interim data that suggested a potential benefit for Huntington's disease. And so that's great. This trial is expected to wrap up in the next year, and then hopefully soon after that, we'll get some data from it. So this is good news too. All right, last gene therapy we're going to talk about, we're going to focus on small molecules and something called splicing. So let's talk about that. So this means that essentially we can provide a drug that alters the instructions to make a protein by changing the code. And so we see this is the normal code. And what we can do is we can insert an extra piece of nucleic acid, so of material, into this messenger as it's being processed. And this additional piece of information essentially acts as a stop sign, and it tells the cell to just get rid of the whole thing. And so this is how it prevents the protein from being made. So this trial recently gave a name to this therapeutic. It's called Votoplam. This is an oral medication, so a little bit easier to access. So oral medication, the phase 2 trial of this was recently completed, and our plans for a phase 3 study. So that's exciting. Let's look at some data from the phase 2. This is 12-month data. And so what we see is we're looking at the amount of mutant Huntington protein in the cerebral spinal fluid. Placebo, there was some decrease. The 5 milligram dose, there was a 21% decrease. And in the higher dose, 10 milligrams, there was a 43% decrease. So this is a little bit of older data from June 2024 that looked at this at 12 months. So that was promising. The 24-month data is what was more recently released. So this is exciting because we see a change in that composite unified Huntington's disease rating scale. So in gray, we see, and remember, down is worse, historical controls get worse by 1.1. Individuals on the low dose still get worse, but by a less amount, and then the same thing with the high dose. Now I'm showing you the total functional capacity. So again, down is worse. Natural history in gray, so not an internal, but an external cohort that they looked at. And this got worse by 0.74, and individuals with both the low and high dose still got worse, but by a less amount. And this is after 2 years. Symbol digit modalities. This is one of the thinking and memory tests. And we see kind of the same thing. The individuals who are historical controls got worse, and so did individuals on the low dose, but less so. And there's some suggestion that these guys did pretty well when they were on the high dose. Okay, so now we're looking at neurofilament light chain. And so remember, this is that distress signal that our brains send out. And this increases about 12% per year just based on natural history data, based on what we know of HD. Individuals who got the low dose got worse by about there was a lowering. I misspoke. I'm going to go back. So there was a lowering of data. So here I changed it up on you. Lower is better. The people who got the low dose, there was a decrease in the amount of this distress signal. Individuals who got the high dose, there was even further decrease. And so that is really promising. And there's no gray bar here. There's no control because the control is comparing someone to their baseline. All right, so this was well tolerated, no dose limiting toxicities, good adverse event profile. They are starting a phase 3 clinical trial that will probably start to enroll patients in the spring. They are looking for people who are at the very earliest stages of HD. So they're still functioning at their normal job, doing normal finances, all of that, but have like some hints of motor changes or possible thinking and memory changes. So that's very exciting. So I wanted to thank everybody for your attention. I wanted to thank everybody who's been in a clinical trial and participated, everybody who's driven someone to a clinical trial. It is such a selfless thing, and it is the thing that will provide us with a treatment eventually. So thank you so much for your attention. If you're interested in hearing more about research, any of these trials, or participating research, this is our QR code for our research website. You're also welcome to call our research line, or if you have clinical questions, this is our clinic information. Everyone is welcome to just touch base with me. If you have any questions for me, I will be around for the rest of the morning. Thank you so much.
All right. Again, I'm Megan Salinas. I'm the medical director of Rocky Mountain Movement Disorder Center, which is a Huntington Disease Center of Excellence. And I also am a principal investigator at Cell, Colorado, and a board member of the Movement Disorders Foundation. These are my disclosures, really not giving any conflict of interest for any of the information I'm providing today. All right, so we're going to go over a handful of studies, some of which we discussed last year, and then they had recent updates, which is very exciting. And then we're going to cover Skyhawk has a new treatment in trials. So first, we're going to discuss Proof HD, which is a chemical called predopidine. So this is a small molecule, and it is being investigated for both Huntington disease and ALS, or Lou Gehrig's disease. The nice thing, just like with the trials that Dr. Forbes was just mentioning, this is an oral medication taken twice a day, which makes it much more potentially accessible for individuals. This works by activating the sigma-1 receptor. And in just a minute, I'll talk about why that is helpful. Okay, and then it's looking, let's see, let's go ahead and skip there. All right, so predopidine activation increases S1R, the sigma-1 receptor, and this is helpful in more than one way. So it can help, do we have a laser? There we go. So first, it can help clear out toxic proteins. And as Dr. Forbes went over, mutant Huntington is an abnormally folded protein. And so it can help to clear out the mutant Huntington from the cells. It can also increase energy production of the individual cells. This is important because it takes energy to help clear out and stay healthy for the brain cells. It decreases cellular stress. So that neurofilament light chain that we were discussing earlier is a marker of brain cell health, or if it's increased, brain cell stress. And so it can help brain cells recover from injuries. And then neuronal connectivity. So this can help brain cells maintain those connections. So you have brain cells that have arms and connections that reach out to communicate with other brain cells, and those make circuits. That's very important for control over movement. So with these kind of maintenance and health of your brain cells talking to each other, this is very important for appropriate movement. And then decreased inflammation. With neurodegenerative conditions, so those are diseases that have dying back of brain cells, so certainly Huntington's disease, but also Parkinson's, Alzheimer's, we are finding more and more that inflammation in the brain cells and around in the supporting tissues can really drive the disease progression. And so if we can decrease the inflammation in the brain cells, that can potentially slow down the disease process. All right, so we discussed this last year, but I'll go over it again because you're probably overwhelmed with different trials and won't remember year to year. Okay, so this was a larger study. It was a phase 3 design. And so there was many more individuals enrolled in this study than, let's say, the Unicure study, which is a phase 1/2. It was double-blind and placebo-controlled. You can see that there were many sites both in the US and Europe. And it was looking at earlier stage Huntington's disease. So these are individuals who do have symptoms of Huntington's. And then their functional capacity goes from 13 is functioning normally to, slightly impaired. All right. And so this was a longer study. They had 65 weeks of treatment, and then they had an extension period up to 78 weeks. You can see that it was a 1-to-1 randomization of about 500 patients. And the good news is about 92% of individuals completed the study. This is a very high rate, which is what it tells me is that this is well tolerated. People were able to take the medication twice a day. There weren't limiting side effects that would make people want to drop from the trial. The primary endpoint was a change in the total functional capacity at the week 65. And then the secondary endpoint that they were looking at is that composite Unified Huntington's Disease Rating Scale at week 65 as well. And so I know Dr. Forbes went over the different components of the composite UHDRS, so I won't repeat that here. Unfortunately, the phase 3 study did not meet their primary endpoint, meaning that the total functional capacity did not show a statistical significant change at the 65-week mark. However, even in the early analysis, they carved out a plan to look at individuals who were not on anti-dopaminergic medications. So those are medications that are used to treat motor symptoms of chorea or occasionally mood or psychiatric problems. So without having those medications on board, I think I'm echoing myself. Okay. Without having the anti-dopaminergic medications, or another term for it is neuroleptics, on board, then it was a more clear-cut picture of how an individual responded to predopamine. So it is known that anti-dopaminergic medications can cause side effects. So not just by lowering the amount of chorea or those extra movements that an individual has from Huntington's, but it can also cause muscle stiffness, slower movements, decreased size of movements, almost Parkinson-like symptoms. And so it really can cloud the evaluation of an investigational medication. All right. And so another point that they saw early on is that the Q motor assessments did show an improvement, even though the primary endpoint was not met. And so overall, this is where we left off last year. So let's talk about the updates. So this was just recent, a little over a month ago. September was an exciting time for HD announcements. So they finished their analysis of individuals who were off anti-dopaminergic medications. And so this was published in Nature Medicine by Royalman and colleagues. And so we can go through their sub-analysis. So here is the composite UHDRS, okay? And it shows the change in that score, as well as the difference of change over time. So the dotted line is placebo, the solid line is the predopamine. And again, these are for individuals who were not on anti-dopaminergic medications. So you can see here at the beginning, initially there was some potentially small improvement or stabilization. Again, the vertical bars here show the range of possibility of the data. And then over time, there still was a slight worsening of motor function or the composite function, but not at the same rate earlier on as placebo. And so it was clinically significant in terms of the slower rate of disease progression between weeks really 12 and then 52. And so we can't really say after week 52 how that's going to look. There are significant limitations to this sub-analysis, which I'll get to in the next slide. But overall, this raises the question, hey, does this help more than we thought it would? If someone is not taking antidopaminergic medications, we can see the change in their function a bit easier. Then we have over here looking at two other measures. And so we have for cognitive change here, you can see that, again, the predopidine arm is in the solid line and the placebo is in the dashed line here. And the word recall test, which is a type of cognitive test, actually improved with placebo or with predopidine compared to placebo. And so that is also suggestive that maybe this medication is helpful. And then we have the Q motor as well. Again, the solid line being predopidine. You can see that maybe more stabilization over time than the placebo group. Okay, so overall, with the individuals who were not taking the antidopaminergic medications, the composite UHDRS, a cognitive measure, and a motor function measure all show possible slowing of disease progression. Okay, so one big thing is that if a study doesn't meet their primary endpoint, then we cannot say with confidence that any of their other secondary analyses are valid. Okay, so the data that I just showed you on the prior slide is a suggestion. The study was not designed to look at that particular sub-analysis group of individuals who were not on antidopaminergic medications. And so it was not designed with the number of patients, the duration of time, and other kind of items on the protocol to be able to tell statistically if that really did slow down disease progression for those without antidopaminergic medications. All right, so strengths of the phase 3 study is, it was very solidly designed in the sense that it was randomized, double-blind, placebo-controlled. Again, well-tolerated with a high completion rate. Again, they thought that there was a good chance that the subgroup who were not on antidopaminergic medication may have a more clear signal to analyze, and indeed they were right. Limitations, again, the primary and secondary endpoints were not met with all participants, which limits our ability to interpret any other analyses. They were not necessarily planning for as many individuals to be on antidopaminergic medications that were actually enrolled in the trial. So more people joined the trial with taking antidopaminergic medications. And this trial was ongoing during COVID-19. So there's some changes related to that it's hard to kind of quantify how that would impact the results. And then, of course, here, this reiterates that subgroup that did have the suggestion of disease slowing in both the composite UHDRS and motor cognitive measures, there's different types of statistical risks. And so this is a risk of a type 1 error. This basically means that you are looking at data that may show a signal of efficacy or positive benefit to the patient when there really isn't. And so that's an inherent problem with the statistics of the subgroup analysis. All right. Okay. So what does this all mean? If they didn't meet their primary or secondary endpoints, they came out with that publication just over a month ago with that subgroup analysis with individuals not taking antidopaminergic medications. So essentially, the takeaway is, hey, this may still work. We just didn't design the trial with the right patients to see the signal. And so really a confirmatory study would be necessary to enroll mostly individuals who are not taking antidopaminergic medications to see if that suggested signal is true. And indeed, that is what they're going to do. So they're going to do another trial, hopefully starting next year. And again, looking largely at recruiting participants who are not taking antidopaminergic medication so that they can more clearly find that signal of benefit if there is one. They may consider also having a small subgroup that may be on a very low dose antidopaminergic medication. So the question that they're trying to answer there is, okay, well, we know that there's not a good signal, all takers taking antidopaminergic medications. What if you were just on a tiny little whiff of antidopaminergic medication? Would we see a signal? Would that be okay? We don't know. And so they're also going to look at that. Of note, they did go into the European FDA equivalent and were denied basically approval without doing additional studies. Okay, let's move on to AskBio. So AskBio works very differently. So cholesterol and brain function. So interestingly, your brain has about 25% of your cholesterol. So it's very important for the integrity of your brain cell membranes. And brain cell membranes are important for the function of cell-to-cell communication. So those brain cells with the arm reaching out to talk to the other brain cell, that's what we're talking about with the synaptic activity or connectivity. Also, it's important for mitochondrial function. So the mitochondria are your powerhouse generators of your cells. And so they make all the energy that's needed to help keep your brain cell healthy. And so it helps to reduce brain cell stress, so decreasing potentially neurofilament, and increases cell survival. So overall, a particular type of cholesterol is very important in brain health, both at the kind of cellular level and connectivity and circuit level. Okay. So how does this relate to Huntington's disease and other neurodegenerative disorders? So over here, if you have a dysregulation of brain cell cholesterol, then you can have problems with many different areas. So excitotoxicity, basically this happens when the brain cells are talking to each other and they are talking too much. They're sending too many excitatory or action signals to the next brain cell. And so your circuits are overactive. And so this is problematic. You can imagine someone being overworked or electronic being overused, and it can burn out, right? And so the same with a brain cell. You have axonal transport defects. So in order for important proteins to go from the cell body out to communicate in that arm that's reaching out to the next brain cell, you need kind of like a ladder or a highway that those proteins can travel along. And that is impaired here. Again, impaired energy metabolism. So if your brain cells aren't able to make the energy appropriate for other cell functions, like taking out the trash of abnormally folded protein, then it's not going to be a healthy cell. And then transcriptional dysregulations. Boy, that's a mouthful, huh? All right. So this basically says that the blueprint of your DNA, when it's being copied to then make proteins, that process of copying your blueprint goes awry. And so, of course, we've all probably followed a set of instructions or a recipe with cooking. So your product is going to be as good as the recipe that you are given. And so if that is copied incorrectly, then your output or what you finish making with your recipe is going to be impaired. So eventually these can culminate in brain cell death. So AskBio has found that a very particular type of cholesterol is decreased in Huntington's disease. And so we're not going to go too much over this, but you can see that in the cortex of the brain, which is the outer layer covering the brain, and involved in a lot of important functions for memory, language, critical thinking, you can see that HD patients have a change in that. And so there's actually a little bit maybe more, but here in the putamen, which is an area involved with movement regulation, there's a significant decrease in this particular type of cholesterol. All right. So this is also delivered through a viral vector. Luckily, Dr. Forbes made my job easier and has already described how that works. So this is essentially a delivery pod that has instructions for how to make the correct protein. And so similarly, they have an injection of this viral vector into the caudate and then putamen. So this is largely ongoing. We do not have top-line results for this. And you can see that they are looking at very early manifest HD, TFC scores 9 to 13. So individuals who have normal level of functioning or some mild impairment. They're also looking at the brain volume, or how much of the brain tissue someone has before it starts to shrink from damage from Huntington's disease. And so they're wanting to have certain amounts of brain tissue left so that their product can work. Okay. So their primary endpoint is really safety. Then they're also looking at changes in week 52 from, clinical measures, so that composite UHDRS, but also biomarkers. So looking at the volume change on imaging of the caudate and putamen, looking at other biomarkers of mutant Huntington, neurofilament light chain, and then the 24-hydroxycholesterol in the blood, and also spinal fluid. Okay. So we will stay tuned on how that trial results. Okay, we're going to change gears pretty dramatically and go from pretty major interventional trials with injections in the brain to an observational study. So we had alluded to earlier that Enroll is a very important trial that's ongoing to really learn everything we can about individuals living with Huntington's. Also individuals who are living with the gene mutation that haven't yet had symptoms develop. And also including in this are people who are, at risk of developing symptoms, but do not know their genetic status. So really this is tracking many different types of individuals over time. So if anyone out there has been involved in Enroll, you'll know that the visits are once a year. They can take a couple hours. We ask a lot of information. We're wanting to see what other health problems someone may have, what lifestyle changes may be happening that could influence their disease. We follow a neuro exam. We do have the option for a blood sample to look at genotyping and also to bank for future studies. Often we will take a family history with this study as well. And it's nice in that Enroll does help individuals who are in need of travel support make it to these annual appointments. And you can see that this is a worldwide program with more and more sites starting up. Okay. So why is this important? Well, really, it's to provide resources and services to the HD community. So for research purposes, it allows us to have lots of biosamples from the blood work, also to have clinical information to go with that. And so we know exactly how that person is doing year to year and what their exam features are, if they're showing symptoms yet, or at what time point they may develop symptoms. And it can help to design trials. So with Unicure study, remember they were using historical controls that were propensity matched or matched with patients in the trial. Well, this is where this information came from. All right. And, overall, this is kind of more in the weeds here, but it's a very standardized evaluation, standardized data that's being recorded and entered in a central database that can be accessed for many different researchers with different goals and objectives. All right. As a sub-study of Enroll, they decided, besides just blood biomarkers, we should probably be tracking spinal fluid biomarkers too to help advance research. And so that's just what they have done. And so they are looking at individuals over time to see year to year if there's any changes in the spinal fluid protein biomarkers. And so that can also help give us really important information, not just to design treatments, but also design trials and potentially prognostication. So if someone in the future, we know exactly kind of the disease progression for certain individuals with patterns of spinal fluid biomarkers. All right. So one kind of newer therapeutic that has not been tested yet in the US, it has been in Australia largely, is one developed by Skyhawk Therapeutics. And so this is pretty similar to Votoplam, and in that it takes the messenger RNA, which is the instructions that were copied down from your DNA blueprint. And in the abnormal mutant Huntington, it inserts a code that says, stop, do not make this protein. And with that, we are able to say for the messenger RNA of the mutant Huntington, do not make this protein, but it does allow for the regular Huntington protein to go on and be made. And so it's a very targeted treatment, potentially. Then this also reduces another mRNA called PMS1. And this PMS1 is thought to contribute to repeat expansion. So, with Huntington's disease, we have a CAG number that often people are given when they are told they have a positive genetic test. And so that repeat expansion is what potentially can be delayed here. And so there may be a way to slow down the symptom onset of this disease. All right, so basically, again, this is looking at the instructions that were copied from the blueprint and telling your brain cell machinery, do not make the mutant Huntington copy, only make the copy from the healthy Huntington gene. And so nice, it is a daily pill and not an infusion in the spinal fluid or treatment directly into the brain. And again, lowers mutant Huntington protein and also potentially slowing down the repeat expansion. They have some initial phase 1 data. And again, this is out of Australia, I believe. And so you can see here on this kind of dark gray line, placebo, and then they were looking at 2 different doses, a 3, kind of a low dose arm, and then a higher dose arm in the dark blue. And over time, you can see that this is the percentage of reduction in mutant Huntington, that the higher dose arm got up to 62% change in the concentration of mutant Huntingtons. So it was able to significantly reduce the amount of mutant Huntington protein in the spinal fluid. And again, this is, looking at, excuse me, I guess this is in the serum for this graph. But this does not necessarily look at clinical change, right? This is just looking at biomarkers in an early phase 1 study. And so they have a phase 2/3 that is being enrolled again in Australia, and New Zealand. Hopefully, and they were just speaking to this at the HSG Congress last weekend, that they're hoping to bring it to the US to be determined. All right. And so hopefully with this phase 2/3 study, besides just biomarker reduction of mutant Huntingtons, we can see if clinically it helps people, which is very important. All right. So just to kind of conclude, why should someone participate in a clinical trial? Well, first, we do not have any FDA-approved treatments to slow down the disease progression in Huntington's disease yet. And so it may be that you would have access to a potentially disease-altering treatment by participating in a trial. Altruism. So to kind of repeat what Dr. Forbes has said earlier, giving of your time and efforts really helps science move forward, and we can't do it without our participants. You do get monitored very closely in a clinical trial, and so this may be a different level of care than you would have otherwise had access to with your local care providers. It also provides hope, right? That we are moving the science forward, and hopefully we'll have a treatment soon that can slow things down. All right. So, I work at the Rocky Mountain Movement Disorders Center with Lucy Dreyer and Liza Heap here. And we are very dedicated to helping individuals improve their quality of life and help them with their Huntington's disease. This is also a disease that the whole family shares, and so they're caregivers as well. We try to support as we can. We are also dedicated in the CenexCell research portion to providing opportunities to patients for clinical trial opportunities. In no way should you feel after this talk any obligation to participate in clinical trials. These are options for you to investigate, to learn about, and to decide what's the right fit for you. I think that's it. Okay. Any questions?
Next, we will have Emily Oldani.
Hi, so I'm one of the researchers in Dr. Sunil Kumar's lab over at the University of Denver, and we don't do anything clinical, but we are in general looking to develop lead compounds to be good drugs to treat Parkinson's, Lewy body dementia. Currently, we started an Alzheimer's project, and for this, we're going to focus on our Huntington disease research. So protein is a biomolecule that can aggregate or clump in many neurologic diseases. So it starts by being monomeric, which is just one copy. That becomes oligomers, which are several copies. That can become protofibrils, which then become those inclearable, insoluble amyloid fibrils that lead to diseased brain cells that lead to that phenotype that you see in neurologic diseases. Our drugs aim to stop this. So if we're just looking at it from aging and neurologic diseases, there's a healthy brain and a diseased brain. You have that atrophy of the brain overall, neurons start to fall apart and die. These include many different ones, but our research is specifically focusing on Parkinson's disease, and Huntington's disease for the scope of this grant. One thing that I do really want to let you guys know is essentially any biomolecule is a Lego. And the way Legos interact by having specific structures that can allow them to perform specific functions and interact with certain other shapes, that's kind of a unifying principle behind a lot of biochemistry. So specifically, our drugs are designed to fit really well with the shape of proteins that are involved in different neurologic diseases. So there's these things called beta sheets that can form those really insoluble things. There's also a lot of things called alpha helix, and our drugs are the right shapes to go with that. You have to have folding for each protein. If it doesn't fold right, it's not going to be able to perform its job. So that's what a lot of people have talked about so far today with Huntington protein not really folding into a uniform shape or the correct shape. Certain shapes can also become something that can act as a sponge and siphon out anything that would be really helpful in a cell, like RNA that's trying to go produce protein that's functional in a different region of the cell, and proteins that are trying to do their own job and sequester them from being able to perform their normal functions. And then a lot of them can become too strong to break up. So our drugs aim to target that, and they're kind of the best of both worlds because you often have small molecules that have very low specificity, but can get into almost any region of the body or cells or organs, or antibodies, which are very, very specific, but they're very, very big. So we're trying to balance between too small and specific. Our drugs fall a lot closer to the small molecule side, and then they're a lot cheaper and more specific and easier to control than siRNA, which is the current main direction that a lot of Huntington disease research is going towards. So once again, just really bringing home that point of Huntington protein aggregates by being monomeric and then oligomeric insoluble fibrils. We want to disrupt that with the addition of our drugs by breaking it back into just oligomeric and monomeric protein. So we're targeting those specific structures, and then we kind of group this goal into two sub-aims, which would be preventing the clumping, preventative care, or inhibiting, and then disease treatment, which would be breaking up those clumps, which would be just a treatment strategy. So the aim of our drugs is to return the brain from being something that is becoming atrophic to something that's a lot more healthy by breaking up those protein fibrils. And then we have a general therapeutic pipeline that our lab works through. So we have HEX cells, which are just a particular type of human cells that you can grow really well in a dish in lab environments, and you can tell them to do all sorts of very specific things. We use them to express proteins that are involved in Huntington or Parkinson's disease with this fluorescent tag on them so that we can find it always being bright green and know exactly where it is and if it's aggregating or not. C. elegans, which is a flatworm that is really sensitive to neurologic diseases that humans suffer from, but it's really nice because they're small, they're see-through, and they only live for about 2 weeks. So you can get a lot of information out of them. Primary neuron culture, and then mouse models. With our therapeutics for Parkinson's disease, so far we have hit the stage of working in mice, and with Huntington, we just reached the point of working in C. elegans. So one thing to remember is our Parkinson's disease research began 8 years ago, and our Huntington's disease research began last year with the start of this grant. Just going through, you start to narrow that target so you start with a large library of molecules, and then you narrow it down as you find more and more leads. So our Parkinson's disease and Lewy body dementia are in that phase, and then our Huntington's disease model is a lot slower behind or further behind, but it is moving forward. We do believe that we'll be able to move towards using our molecule in human trials for Parkinson's in the next year. But we've screened over 600 drugs now with our Huntington's disease model and are working on validating our hits and beginning our worm work. We are working on moving forward with continued funding in order to continue to advance our Huntington project. So within the next couple of years, we aim to be screening these drugs in the worms, getting all of the information we can out of them. So far, we've just been able to see, yes, it looks like it's working visually by seeing if there's aggregation or not. Not any sort of health monitors that you can do in those worms. And then we're working on further refining the drug pharmaceutical properties for the best efficacy and the most optimized safety, just by seeing what sort of products would come from our molecule being taken as like an oral drug or intravenously. Over time, we do want to move forward with a Huntington's disease mouse model, as well as kind of focus on making this project become more of a mature project that is supported by a full lab instead of just me in our lab. And then we'd like to move forward with some machine learning since we have a large data set and would like to further refine the information that we're getting out of it instead of just using it to find out what an actual hit is. So I'm going to give you guys some of our preliminary data so far. So this is prevention. So this is if we treat our Huntington's disease expressing cells with our molecule and then induce them to aggregate. And then it's just measuring how aggregated they get. So white is going to be got worse than baseline. Yellow is going to be not great. And then pink is going to be, it significantly reduced the aggregation. So one box is one drug. That's how many I've screened so far. That's how many our chemists have made. It's 602 currently. And then when we flip that for the treatment score, which would be treating or inducing the aggregation and then treating with that molecule, we also see many hits. When we sum those together, we can refine that to get the best molecule to both prevent and treat. So keeping the Huntington protein from aggregating, but also breaking it up and keeping that from seeding further aggregation as well. You can see there's fewer hits, which makes it more feasible to move forward with. And then this is just what a healthy cell on the left looks like. So you can see there's not really bright spots of green in that. The blue is the nucleus. We expect to see that. It's just marking where it is. And then a healthy worm where we just see green all the way through. In our disease models, so we have a lot of those bright spots, which are called puncta. Those are those aggregates. And we see that in the worms as well. And then those fibrils are just from protein in a test tube. We can get it to aggregate. When we treat it with our drug, we get this return to looking a lot more like the healthy model in the cell line, the worm line. And then we don't really see aggregates. We just see broken up clumps of oligomer and monomeric protein in the treated. And then this next slide is kind of the most exciting. We just did some overnight imaging to see if we can watch those large droplets dissolve in real time. So it looks like this, but if you focus in on the middle, the droplet in the lower quadrant is going to dissolve and become diffuse, and you can see it stop being an aggregate and something that's spread throughout the cell, not necessarily acting as an unclearable thing and not likely causing that cell to die. And with that, I do want to thank the lab that I work in, because science isn't a just one person job. We have a lot of people that work on this project, even though I'm the only one doing the testing. So we got the use of an overnight microscope from a collaborator and her graduate student. We have 6 chemists that are working on making all of those drugs for me, my PI, Dr. Sunil Kumar, and then my undergraduate, Naya, has been working with the worms for me. With that, can I take any questions?
All right.
All right. Thank you. This will be a shorter talk than the other one, but we have some really exciting things that I wanted to talk about for my research here in Huntington's disease. And this is the relationship between sleep and cognition in both Huntington's and Parkinson's. Okay, so an overview of the next 15 minutes or so is we're going to look at why are we looking at neurodegeneration outside of Huntington's? How does sleep affect neurodegenerative conditions? What are the goals of the study that I'm doing here at the University of Colorado? And how will results of this study help people with not only Huntington's, but potentially other neurodegenerative conditions like Parkinson's disease? So let's just talk for a moment about what are neurodegenerative diseases. So these are disorders that occur because cells in the central nervous system stop working. And so these are progressive, so they tend to progress over time with worsening symptoms. And there are many of these. There's Parkinson's, Huntington's, Alzheimer's, ALS, SMA, spinocerebellar ataxias. And I could go on, but we're really going to focus on Huntington's, of course, today. And I'm going to touch a little bit on Parkinson's also. So we all know about Huntington's, and I know I spent a lot of time on that image on the left on our prior talk, just how the abnormal CAG repeat expands, resulting in aggregation and toxic fragments of the mutant protein, and this happens first and foremost in the striatum. And we also know a little bit about the progression on the right. So over time, functional abilities go down, and as those start to decrease, we see chorea and other motor impairments increase, as well as cognitive impairment and/or dementia. And typically, onset is in the mid-40s. So we're going to pivot for a moment, and I'm just going to say a few words about Parkinson's disease. And I'll explain why we're even talking about this. So this is another progressive neurodegenerative condition. And there are a lot of causes. So in Huntington's, we know every single case is caused by the exact same thing. It's that expansion in the CAG. Parkinson's, it's more varied. So that about 15% of people have a genetic cause. That could be one of many different genetic causes. There's also environmental and many unknown causes. And there's an accumulation of a protein. So it's a different protein than it accumulates in Huntington's, but it is still a protein that ends up aggregating and being toxic to the cell. So that's alpha-synuclein. We can see a neuron up here, and this pink inclusion right there is what's called a Lewy body. It's a bunch of alpha-synuclein together, and that really wreaks havoc on the neuron, and the neuron dies off. And so it's kind of the same idea as in Huntington's. You have buildup of protein, the neuron dies off. Below, we can see it also hits in the very deep part of the brain. So this is a substantia nigra. It is close to the striatum and has projections, so they kind of talk to each other. And we see a healthy substantia nigra up here with nice dark stripes, and they lose that as these neurons die. Symptoms in Parkinson's are motor symptoms, mood symptoms, and cognitive decline. And there is no curative or disease-modifying treatment in Parkinson's either. Now, we're going to pivot a little bit and talk about how sleep affects the brain. So sleep dysfunction is associated with cognitive impairment in healthy adults. So even people who are healthy, who don't have any neurologic conditions, sleep dysfunction will affect cognition. And more so in people with neurodegenerative conditions. In Parkinson's disease, we have more data on sleep. We know that increased slow-wave sleep, so a type of sleep that I'm going to talk a little bit more about, is associated with better cognitive performance. And we can see this on the graph on the right. Down here is the cognitive score, so better cognition is out here. This, where it says N3%, that's the percent of slow-wave sleep, restful sleep, sleep that is restorative to your brain. So the more sleep you get is up here. And we can see that people who have better cognitive scores tend to have higher amounts of slow-wave sleep. And so that's what this shows. In Huntington's, we know some things about sleep. We know HD is associated, sleep impairment in HD is associated with cognitive impairment, with mood disorders. QOL is quality of life. So there's worse quality of life in people who have sleep dysfunction, not only in patients, but in care partners. So if you're a care partner of somebody who has sleep dysfunction, you might empathize with this. Can getting good sleep help clear out these abnormal proteins that build up and destroy our brain cells? And so that's really the heart of the question here. And that is pertinent in Huntington's, where we have buildup of this toxic Huntington protein. It's also pertinent in things like Parkinson's, where we have buildup of another type of protein. So I want to spend a moment and just talk about sleep. So a lot of the times when we're asleep or we see someone sleeping, we kind of think about sleep as this like binary thing, where you're either awake or you're asleep. And that's not really the case. Our brain does different things as we're sleeping, and we call that different sleep stages. So when we're awake, we know our EEG, electroencephalography, there is alpha waves, so we know our brain's doing a certain electrical activity. As we go into sleep, so this is light sleep, theta waves, and 2 is where we spend most of our sleep, and this has specific electrical footprints. And then down here, N3, this is slow wave sleep. So this is these delta waves, these big rolling waves. That is what we think is very helpful for our brains. And we kind of cycle in and out of this. As we go through it, we go through REM sleep, rapid eye movement sleep. and then go back down. And so this is kind of the textbook case of what our night looks like. So our brain is doing different things. Now, when we sleep, we think the normal cleanup system in our brain is preferentially active. So we know we have the lymphatic system in our body. Our brain has a parallel. We call it the G-lymphatic or glymphatic system. And so this is our brain's normal central waste removal system. So as we go through our day, even in a totally healthy brain, your brain is producing metabolic waste products that need to be cleared out. And this is the system that helps clear out those products. And so it goes, this flow helps all of these abnormal little proteins get pushed around the vein and essentially taken out of the central nervous system. And so in addition to the normal metabolic waste of our brain that it normally produces just from being so active, it will do this, we think, with all the abnormal proteins that build up in Huntington's and Parkinson's. Slow wave sleep especially helps the lymphatic system. So we think slow wave sleep or glymphatic clearance is preferentially active during slow wave sleep. And so these are connected. And so we asked the question, could glymphatic system help remove these abnormal proteins? Like I mentioned before, a little bit more is known about sleep in Parkinson's disease. This is a healthy adult. This is as they oscillate through different stages of sleep overnight. In Parkinson's disease, this is so much more fragmented, and you can see it here. And so a lot of these might be arousals, but not necessarily waking up. So there are a lot of times at night where you might get up a little bit, turn over, your brain wakes up, but you don't really wake up, so you don't notice it. So people can have a lot of arousals and then not feel rested in the morning. They can also have a lot of just awakenings where they are just waking up overnight. And in Parkinson's, sleep fragmentation, where it kind of you wake up, is 3 times more common than age-matched older adults. People with Parkinson's take longer to fall asleep. They wake up more often. There's decrease in that deep sleep that we think is protective for the brain, and decrease in dream sleep. In HD, less is known. There have been some studies with what's called a polysomnography. This is a sleep study. This is where you come into the sleep lab and they put all those stickers on your head and we measure the electrical activity as you're sleeping so we know what stage of sleep you're in, and measure many other things. The research that has been done in Huntington's has shown that there is decreased sleep efficiency. So people are spending a lot of time in bed, but not as much time sleeping. Decreased slow wave sleep, decreased REM sleep, increase of this light sleep, increased wake after sleep onset, and increased time it takes to get to REM sleep. Now, what's been done in glymphatic clearance in Huntington's? So this is a really newer field. And this paper just came out this year, where they looked at people and tried to assess how well their clearance of abnormal proteins is from the brain. They used non-invasive MRI techniques, and they compared healthy controls to people who were pre-manifest, so people who had the gene for HD but didn't have symptoms yet, and people who had manifest HD, so had symptoms of Huntington's. And on the right, you can see what they found. So in the healthy controls, they found this MALPS. This is the imaging technique, one of the imaging techniques that they used. The higher it is, the more clearance that abnormal proteins have from the brain. So they found that in healthy controls, this was higher as compared to people with manifest Huntington's. Interestingly, people who were pre-manifest, who didn't have symptoms of Huntington's, were different than healthy controls. There was a difference there. So there's something going on here that we're not totally sure about, and we need more research on. So I'm going to talk a little bit about the study that I'm doing on the relationship between slow wave sleep, cognition, and glymphatic clearance. The goals of the study are essentially to characterize sleep dysfunction in specific stages of HD and compare that to individuals with Parkinson's. So we talk about stages of HD, and a lot of the clinical studies that we're doing now, where it be like one of the ones that we talked about earlier, like the Unicure study or the one that they're studying in the oral pill, we're trying to get people who are very early onset in their course. So people who just have the first suggestions of symptoms, but don't have any functional changes. And so we want to see how people are doing and what their sleep is like in that stage. Oh, it's going forward without me. Okay, then we're trying to understand how how slow wave sleep affects cognition in Huntington specifically, because we don't have a lot of data in that, but information in Parkinson's and healthy aging indicates that these two things are connected. We're trying to understand if fluid movement in the cerebrospinal fluid plays a role, so that lymphatic clearance system. And once we know this, we can really ask the question, could enhancement of sleep be a feasible novel therapeutic target that can slow down the progression of these buildup of disorders where there's buildup of abnormal proteins like Huntington's and Parkinson's? And so, as you might imagine, if we're able to enhance a certain phase of sleep and that will help clear the proteins, it's a little bit of a more accessible and easier approach than things like infusing therapies in the deep part of the brain or infusing things in the spine. So this is the goal. So the study has 3 parts. Part 1 is clinical evaluation and questionnaires. So we're going to look at the Huntington's rating scale, the Unified Huntington's Disease Rating Scale, which we've talked about as an outcome measure in other trials. We do some cognitive evaluations, which nobody enjoys doing, but we are very appreciative for the people who have been bearing with us and completing those. We do some sleep evaluations. We ask people how they perceive their sleep to be, get demographic information, and some just disease characteristics on HD. The second part is the sleep study, or polysomnography. That is when we ask people to come in and spend the night with us in our sleep lab. And people get hooked up to all sorts of things. Get EEG, so stickers on the head, monitoring heart rate, monitoring pulse ox. This is a picture of our sleep lab, and we're really looking to see how people are, essentially the architecture of sleep in people with very early HD. And then part 3 is an MRI. So diffusion tensor imaging along perivascular space. So this individuals can get in the morning before they leave, so after they finish the sleep study. And this is what they looked at in that study that I had mentioned, where they see a difference between healthy controls, people who did not have disease onset yet, and people who had manifest HD. So essentially, it would look like this. Day 1, someone would come in and spend 60, 90 minutes with us to complete some of these evaluations. The next evening, they would spend the night with us getting a polysomnography. And then before they leave the next morning, they would get an MRI. So we've had a handful of people come in and be willing to participate in this study. And this is some of the data that we have. And so essentially, these are just the different stages of sleep. So if this is 100% of your sleep, the least amount is spent in stage 1 sleep, and we see that across HD. So stage 2, this is early HD, Parkinson's, and we have age normative data. So we've been talking a lot about controls. We do not have a control for this study. We are using normative sleep data based on age that's been published in the field. As expected, the most amount of sleep is spent in stage 2 sleep. And then stage 3 sleep did not significantly differ in the data we have so far between the HD stage 2, PD stage 2, and age normative data, and then REM sleep. So this is kind of the architecture of how people are spending their nights. We have some demographic information. So age on average 39, disease duration 13.5 months, CAG repeats on average 41.3, that's just the average. And then we ask people to complete an Epworth sleepiness scale, so tell us how sleepy they are during the day. So this is just perceived sleepiness. This is not needed to be in this study. This is just some information we're gathering on individuals who participate. We also did a Montreal cognitive assessment. I think many of you have probably been through this, where we ask you to name some animals and do some math. And I put in here our total motor score for the UHDRS. So it's pretty low. It's within the range that we usually think of for very early HD. And then what data are we getting on sleep? Well, we're getting sleep efficiency. How much time in bed are you actually spending asleep? Sleep latency. So how long does it take to fall asleep? How quickly do you wake up after you start or after you fall asleep? REM latency. So how long does it take to get to REM? Awakenings, arousals, and desaturations. And so this is what we have. So we have people are somewhat efficient when they're sleeping. This is just for HD. We have the latency, wake after sleep onset, REM latency, awakenings, arousals, desats, and O2 sat. And so this information is very helpful for us to lay a baseline of what sleep looks like for people with very early HD that we can build on to get more information and try to understand, is this an area that we can intervene on to help clear those proteins? So with that, I would like to thank you. If you are interested in hearing more about this trial, I am happy to talk to you about it. You can just come tap me on the shoulder during the next break. We have our QR code to our research page and our research email and phone number.
And last but not least, we do have Dr. Michael Flower, who will be joining us remotely.
Hopefully some slides are coming up. If not, someone will tell me.
We see your slides, yes.
Excellent. So I'm Mike Flower. I'm a clinical research fellow in London. I work in the group with Sarah Tabrizi and Ed Wild in Huntington's Disease Research Centre. Part of the project that I work on, and part of the work that we do in our lab, is something called working a lot on extracellular vesicles. And what we're trying to do with this is measure DNA repair activity and repeat instability in patients in real time. And I'll come on to why we think that's really important soon. The schematic down here is showing a bit of the work that we're doing. So we're working with neurons, both in a dish and in real patients. And the material that they produce and release out into cerebrospinal fluid and into blood, and how we can measure that and why that's really important in Huntington's disease. Because I can't see people there, so if anyone wants to ask any questions or interrupt me, feel free to. Because I've got a lovely picture of the lectern here, but I can't see any people, so feel free to shout up if anyone has any questions. I missed the first couple of talks while I was trying to join, so I may be going over old ground here, but I'll lay a bit of the background to the work that we're doing. But a lot of recent work has really highlighted DNA repair and how important it is in Huntington's disease. This is called a genome-wide study, genome-wide association study. And there have been several iterations over the last few years. And one thing that was very, very striking that's come out of it, this is called a Manhattan plot, but essentially all of these things that look like skyscrapers, so these points that reach above and below these two red lines, are mutations in the genome which affect the age that your disease starts or how fast it progresses. And you don't need to know what all of these genes are, but suffice to say, a lot of them are involved in the DNA repair process. Oh, I can see the camera swiveling. That's quite nice. I might be able to see some people now. Lots of them are involved in DNA repair. There's Huntington itself, but there's things like MSH3, which is a key DNA repair protein. And this really shifted the whole field's interest onto DNA repair. And this is where therapeutics are going a lot of in Huntington's disease, and we're working on them a lot in various models and in people. Clinical trials are currently underway, and we've obviously seen a big success in Huntington's disease with Huntington lowering trial via brain surgery. But there's the next generation of therapies, which we're working on and working with several pharma companies on in affecting DNA repair. But there is a problem. The problem is we can't currently measure DNA repair activity or repeat instability, which is what the repair activity is driving, which is the repeat that causes Huntington's disease getting bigger gradually over time throughout one's life, which is what we want to try and intervene and stop as soon as we can, as early as we can. But the problem is we can't currently measure that in people's brains. We can measure it in blood, but there's very small amount of instability in blood over time. And also the drugs that we're delivering are going directly into the brain. They're not reaching the blood. So we really need a way of measuring what's going on with DNA repair and repeat instability in things like cerebrospinal fluid, which coat the brain and which we can access via a spinal tap or a lumbar puncture. We know from studying the brain that there's tons of repeat instability. So this is our sequencing data in different bits of the brain, and you can see down here. So these are people with Huntington's disease, sadly, after they've died, but they've very kindly donated their tissues. And what we can see is these people have two different chromosomes, one of which has a big repeat expansion on it. Let's see if I can put a laser pointer on. Here we are. so in their blood, you can see they've got, this is at the end, this is at end of life, and you can see there is a little bit of spread, but really in blood, there's not very much change over time. But when you compare that to someone's brain, particularly the striatum, you can see that there's a vast amount of repeat instability. The y-axis, this axis up here, is the length of the repeat that you measure, and there are hundreds of repeats. That this repeat has gotten bigger over time, but hardly any change in blood. What we need is a way to measure this in people during life, in a minimally invasive way that doesn't involve brain surgery, for example. And extracellular vesicles are a way of doing this. And these are small, tiny particles that all cells release, including brain cells, and they release them into the surrounding tissues, including into cerebrospinal fluid, which I said bathes the brain and then carries on down the back, and we can access. And they also go out into blood, and we can access them via blood. This is electron microscopy, where we've taken some of someone's cerebrospinal fluid, isolated these extracellular vesicles, and done very high-powered magnification of them, and you can see that they're these tiny particles encapsulated in fats, which protects what they contain. And that's important because they contain things like DNA, in which we can measure how big the repeat is in someone's brain, as well as RNA, and protein, which allow us to measure how active someone's DNA repair system is in certain brain cells. And we can, from this pool of extracellular vesicles, we can purify up the neuronal ones based on the markers that are on their surface from both the blood and the brain. And we've shown that in these extracellular vesicles, even though we're dealing with tiny quantities of cerebrospinal fluid, it's quite easy to do when you take liters of cerebrospinal fluid, but realistically, in people who are either on a clinical trial or who we want to do diagnostic work on, we're dealing with just around 250 microliters, a tiny amount of CSF. And in that, there's probably only 1 nanogram of DNA, which is just a vanishingly small amount of DNA. And we've shown that in just this small amount of material, we can measure how much bigger the repeat is. So these are 2 patients, and you can see here, this bottom track is the person's repeat length measured in their cerebrospinal fluid, and the top track is as measured in their blood. And you can see that we're capturing exactly the same sort of patterns that we were seeing in people's brain. So this is working. We can also measure the levels of the DNA repair proteins that we want to try and target. That's really useful because A, you can show that your DNA repair treatments, when you inject them into people's brains, are working. They are actually lowering the DNA repair things. But it also lets us work out which people have particularly high or low levels of these DNA repair genes, which might be protective or might be problematic. And in future, when we have a plethora of drugs available for people with Huntington's disease, these sorts of measures will allow us to individualize treatments potentially. You say you've got a particularly high level of activity of this gene, and therefore these sorts of treatments we might want to give to you. But again, the difficulty here has been measuring this in tiny quantities, and we've shown that we can measure these important transcripts, so this RNA and the protein, in tiny quantities, so just 250 or 500 microliters of cerebrospinal fluid, which hasn't been possible before. And by measuring these over time in patients, we can track how repair activity and repeat instability correlate with how people are progressing, which is really important for clinical trials, because if you want to show that your drug is changing something, you need to know how it changes normally. So we've set these methods up. We've already been able to measure. So this is the repeat length in this is just more measures of repeat length in someone's cerebrospinal fluid versus their blood over here. And we're comparing them against different cell models to see how they change. So we, for example, work a lot with stem cells, and we turn our stem cells into striatal neurons. So these are the neurons that are most vulnerable to Huntington's disease. And we treat them with these DNA repair drugs, working with various pharma companies, including Ionis and Takeda and Locus. And we're showing how they reduce repeat instability, both in the cells and in the extracellular vesicles, so that we can then go on to measure it in the CSF as well. So we're developing new methods of measuring repeat instability using extracellular vesicles from tiny quantities of DNA. We're uncovering HD mechanisms and linking how DNA repair activity links up with repeat instability. And we're testing new treatments, working with our own and with various pharmaceutical companies, including Ionis and Takeda and Alnylam and Locus, to test drugs to get them quicker to the through into the clinic. These are just some pretty pictures of the neurons that we culture. So what we do is we take stem cells from patients who kindly donate their cells, and we turn them over the course of a month into these neurons, which are the most vulnerable ones in a Huntington's disease. And then we apply these therapies and we measure how things change, including the repeat instability in the cells themselves and in their extracellular vesicles that they produce, which is essentially a mock-up of the clinical trial that we will be doing in patients. And this is just to show these neurons. This is actually the first human neuronal model that has seen aggregate, so aggregation of the Huntington protein, which you can see here. Is these, they may not mean much, but these bright yellow dots are quite important. They show aggregates of the Huntington protein in a human cell model, which has only previously been done in mouse models in cells. These cells also show lots of other Huntington's disease phenotypes, like the Huntington's disease problems that happen in cells, including producing a very toxic RNA species. So fundamentally, we're uncovering and aiming to stop the DNA repair errors that drive neurodegeneration. We're linking mechanisms to patient change. We're developing really sensitive ways to measure the DNA repair activity and repeat instability in brain, which are going to be fundamental for the next generation of Huntington's disease treatments. And we're doing all of this in stem cells and in patients. And the work and the contribution from MDF has been really fundamental in setting this up. So I'm very grateful for all the support from MDF and from everyone there. And yeah, we're really excited to continue this work and roll out to the clinic. But if anyone has any questions, I think I can see a few people now. I'm going to try and pin it so I can actually make it bigger. But yeah, that's the end of this. But if anyone has any questions, please feel free to fire them off.
First, we'll speak with Dr. Christina Vaughn, Division Chief of Neuropalliative Care and Professor of Neurology and Medicine at the University of Colorado School of Medicine. Dr. Vaughn specializes in movement disorders and hospice and palliative medicine. So please welcome Dr. Vaughn.
So I was asked to speak about 3 topics: palliative care, hospice, and medical aid in dying. My colleague who will be joining me in this session, Crispin Sargent, will speak more about medical aid in dying, so I'll spend less time on that topic. But these topics tend to have more emotion associated with them and are much more clinical than the exciting research-related topics we've been hearing so far. So I'll go ahead and get started. So I wouldn't mind if you would shout out, if you feel comfortable, some words that come to mind when you think of the word or the words palliative care. I'm just curious. What comes to mind? There's really no wrong answer. Providing comfort. Sorry? Support. Anything else? Engaging where we're starting with today. I think this audience is probably a lot more knowledgeable than others in other parts of the country even. I think it depends on what region we're in. Well, palliative care came out of cancer care, actually, originally, but it's evolved to become a lot more appropriate for other conditions that are progressive and serious, such as HD and others. And very briefly, palliative care is medical care focused on improving quality of life for people living with any sort of serious illness at any stage, from the time of diagnosis or any time after that. And if I could really distill it down, it's about living as well as possible, as long as possible in the face of a serious condition. And I really want to emphasize the word living, because all too often when I ask groups, what words come to mind with palliative care, sometimes people think about things other than living. And in fact, it's about living as well as possible. And a typical palliative care team, or at least what we have here, is certainly with the patient and family at the center and several different disciplines working together. The palliative care clinician, which could be a physician or a nurse practitioner or a PA, a nurse or nurses, social work, chaplain or spiritual care, psychologist, and we're lucky now we have a pharmacist in our clinic. And so this makes up the key components of a clinical or an in-clinic palliative care group, ideally. And I'll introduce this topic to you that's a palliative one. It's called total pain. Came out of the palliative care world, and it's the idea that if we want to address a symptom, whether it's pain or something else that's significant, we really can't do as good a job if we're just focused on the physical. We do a much better job and can be a lot more effective if we recognize that physical symptoms have other components too. If you follow this wheel around, there's the emotional side, potentially the spiritual or even existential side, the practical side of living with symptoms or a medical condition or a neurologic condition, the social side. And so that's why palliative care teams have multiple different disciplines as part of the team, because we recognize that if we focused with blinders on just on the physical, or maybe the physical and just the emotional, we'd be missing out on the other impact or the other domains of impact that people have when they're living with such conditions like HD. There are many benefits of having palliative care involved in a chronic condition. Certainly helping with effective symptom relief has shown to improve quality of life, again, by addressing these multiple domains as much as we can, physical, emotional, spiritual, psychosocial, as well as focusing on caregivers. The intent is not just to put blinders on and focus on the patient, but to recognize that whoever is with them, close to them, comes to the visit with them, that's part of who we're focusing on. We try to ask that person or those folks how they're doing. Are there opportunities that we have to help them too? Certainly they're not our patient technically. We're not writing notes on the caregiver and prescribing things, but we are trying to check in with them and see if we can connect them with resources as well, or even to normalize things. Sometimes caregivers or families might be reluctant to bring up something, and if we can get them to do that, sometimes we can normalize or put things into context that they may not have been eager to talk about before. And then because we focus on advanced directives and planning for the future, sometimes we can minimize unnecessary hospitalizations, or the cycle that sometimes happens when people have very advanced disease and might be in and out of the hospital with infections or other things. We might be able to avoid or mitigate that, or emergency visits, or even aggressive treatments at the end of life if somebody doesn't want that, or if it doesn't make sense with their values. And so these are just some of the ways that we strive and actually do help people, patients and families living with a chronic condition. How do we do that? Well, I would say our greatest tool, if you could call it that, is the goals of care conversation, the discussion. This is where we try to understand what matters most to people, what their values and priorities are. All too often in medical care, we can get on automatic pilot, right? Where you come into a medical visit, whatever the specialty is, and we jump straight to the medical and say, okay, how's this symptom? How's the chorea? How's the walking? Let's focus on that. And certainly that's important, but we'd be remiss if we didn't check in about actually what the patient is hoping for and what they're hoping to do, goals that they have. And so goals of care discussions are really how we start, especially our first visit when we're first meeting a patient in clinic. We'll ask questions like, what was life like before you got sick? We really want to understand the story. And while it might feel strange to be in a medical setting with medical people asking you about your life story, what we're trying to do is understand better how things were truly before the disease kicked in and became symptomatic, and understand what's important to people. We'll ask questions about the future. Are there situations that you're worried about or want to avoid? Alternatively, what are you hoping for? Hope and worry are two sides of the same coin, but they're both future-oriented, and we really lean on those questions a lot in our visits to try and understand where people are at, what they're expecting or hoping for. So the goals of care discussion is really the foundation for additional discussions regarding planning for the future, which includes medical decision-making. We really enjoy and like to help patients and families support them around medical decisions. For example, if somebody with mid to late stage Huntington's disease is being told by their primary care doctor, it's time for your colonoscopy. Maybe that makes sense, maybe it doesn't. So for example, that could be a discussion we'd have about, let's talk about that. Does it make sense to get this colonoscopy or this elective procedure? Maybe or maybe not. So talking through that and not just automatically moving forward with whatever other medical specialties are recommending is part of what we like to help with. And advanced care planning as well. Planning in advance for the what ifs of the future. Getting the patient's voice, capturing their preferences as soon as we can, recognizing that they can change certainly over time, but having those conversations earlier just to set us up for success so that if things happen that go wrong or medical emergencies happen, we at least can lean on prior discussions about what would be acceptable for that person or not as far as medical interventions. So we talk a lot about what if medical scenarios. What if you won't be able to swallow safely in the future? What are our options? Would you be open to the possibility of artificial nutrition through a tube? Some people say, yeah, I think that sounds good if it's going to extend my life because life prolongation is what's most important to me. Other people say, you know what, I've seen people with feeding tubes. I definitely don't want that. But we don't know until we ask. And that's what this is about. Advanced care planning is about asking these questions, not focused only on these things, but certainly making sure these are part of our visits. And then documenting this, right? It's one thing to have the conversation. It's another thing to actually put it in writing, and we help with that. People don't realize a lot of times that you don't need an actual attorney to document your medical wishes, especially in Colorado. Medical providers can help you with that. You don't have to pay any money. You don't have to go through special hoops. We can document that with you. And where can you find palliative care? Actually, in 3 different types of settings. One is in the hospital. If you're hospitalized for whatever reason, palliative care teams usually exist in major hospitals. In fact, Dr. Forbes and I just shared a patient with advanced Huntington's who was hospitalized for pneumonia. And having palliative care involved is absolutely possible in a hospital setting. In the clinic, that's where I spend a lot of my time in a non-emergent setting, having a clinic visit. And then third is community-based palliative care programs. Sometimes people aren't aware of these. They exist. They're usually affiliated with a hospice. It's a different arm. And this is a team that comes to the home and visits, or wherever the patient is, and visits with them every 4 to 6 weeks. It's not very often, but it is another set of eyes. And the palliative care team can come to the home or the facility if somebody's in one. So hopefully I have limited time for this talk, but we'll have a Q&A in a few minutes. Hopefully I've shared with you the idea that palliative care is about living and being proactive and trying to raise up what's most important to people. And I'll remind you that the word palliative itself comes from palliare, which means to cloak, kind of like the idea of a mantle. And I love this visual because it's really meant to be like another layer or a cloak of support, just another dimension of support. And I mention that only because sometimes people say, hey, why don't you change the name to something else other than palliative? Palliative has a bad rap. And I say, no, I love this word. It makes sense. All right. So when should this occur? As I mentioned, it can happen anytime from the time of diagnosis or afterwards. It's never too early. There's not like a right time, right? Sometimes people say, even colleagues are like, well, we're not ready for that yet. Why not? I can also appreciate that it might be a burden to have yet another medical visit, so we do want to be sensitive to that. But there's no reason to wait for palliative care to have these conversations. Ideally, it's proactive and not reactive. Triggers to involve palliative care could include times when you have complex decisions that you want to discuss around surgery, transitions in care, a new medical diagnosis, some other new problem that's started, which can happen. Advanced care planning, if you want additional help with symptoms or another perspective to help with physical or other symptoms. And then if there's real need for support of the care partner or family. These are all possible reasons to trigger a palliative care referral. And how can you don't have to have a palliative care referral or see a palliative care team, to actually start having a palliative approach in your regular neurology or primary care visits. Ways you could do that or empower you to have these conversations with your pre-existing medical team could be to ask questions like, I'd like to discuss my priorities and what's important to me, what's most important to me. If you initiate that or the family initiates that, that could start a palliative type conversation in a regular visit without having to go and see a new team. How about, can we talk about a Huntington's disease roadmap for the future? That could also initiate a conversation. Another one, future-oriented, might be, what do you expect things to be like for me in 5 years? Admittedly, we're not that great at prognosis, but we do our best, leaning on what we know about the disease course, what we know about you, the patient or the person in front of us. So we can try to lay out a roadmap or talk about what to expect in the coming years. And then another thing you could ask could be, can we discuss some what ifs of the future? This also could lead to a more palliative discussion. So that's my bit about palliative care. I'll spend a little less time on hospice care. Anything that comes to mind that you want to shout out when you think of the word hospice? What comes to mind first? Dying. Thank you for being honest. Yeah. Anything else? Yeah, I mean, you went straight to the heart of it. A lot of people think about dying. And I think hospice teams would actually appeal to you that while, yes, patients enrolled in hospice are towards the end of life, it's still about living because they're still with us and they're trying to optimize the days or weeks or months that they have left. So it truly is actually about both dying, but also living. And so it too is medical care focused on providing comfort for people who have a life expectancy of 6 months or less, when the primary goals really are symptom management and quality of life. That's really what it's intended to be. I think all too often in the US especially, we get hospice involved very late, and it might be a reactive referral, like things are going downhill really fast for whatever the disease is, let's get hospice in, and then the person passes away within days or short weeks. It's intended to be involved sooner, upstream from that, ideally, if possible, but it can be hard to predict when somebody is eligible for hospice or not. It's meant to be person-centered, and it comes to where the patient lives, right? If they're at home, hospice comes to them. If they're in a facility, hospice comes to them. And it's a team, also like our palliative team, this time led by a nurse with other domains or other specialists joining. It is a Medicare benefit. All Medicare and Medicare Advantage enrollees have a right to hospice care. Most major insurances also cover hospice care, so there's no out-of-pocket cost for the essence of what hospice is. It's not a 24/7 service in person. It's not 24/7 bedside care. It doesn't replace, if someone is in a nursing home, doesn't replace the nursing home care, and it does not hasten death. That's not the goal. It does, hospice teams all have a 24/7 phone number, so they become like the new 911 when people are enrolled in hospice. They also offer, all hospices have to offer bereavement support to the family 13 months for over a year after someone does die. So that's just a snapshot of some hospice highlights to share with you. To sum it up, hospice is both a service and a philosophy. Service meaning they come and they do things, they take vitals and check symptoms and adjust medications. But the philosophy piece means that this makes sense for patients who have a limited lifespan and who want to focus and prioritize comfort, who aren't necessarily interested in going back to the hospital or having medical tests or procedures. The goal is comfort. So when is the right time for hospice enrollment? It can be tricky. One thing that I rely on is the surprise question. I'll ask myself, would I be surprised if this patient in front of me were to die in the next 6 months, to die naturally? That's a different question than saying, do I predict it? So there are some instances where I see a patient, in fact, this happened yesterday in clinic, where I see a patient who I wouldn't be surprised if they died in 6 months, but maybe I wouldn't be surprised if they lived beyond 6 months. In my opinion, these folks are eligible for hospice care. And I talk to the hospice teams and they often feel the same way. And this is a way to think about getting hospice involved sooner if the person's goals are truly thinking about comfort. And again, it brings medical care to the patient. And typically they're not going back to the hospital or having tests. When it comes to the hospice criteria for Huntington's disease and similar conditions, neurologic, things that we're looking at are if the person is transitioned to no longer independently walking, but really relying on a wheelchair or strictly in bed. If they're no longer able to carry out activities of daily living and requiring assistance for all or most of them, if there's a critical nutritional impairment, if there are life-threatening complications, breathing problems, and so on. And we're paying attention to activity level, their ability to provide their own self-care, again, nutrition. And sometimes people become really sleepy, not just with HD, but with other neurologic conditions towards the end of life, where they're spending most of their time sleeping on and off throughout the day or mostly in bed. These are some of the factors, this and weight loss, that we're thinking about when we're trying to gauge whether somebody is hospice appropriate. And lastly, just a couple of slides about medical aid in dying to segue into Crispin's discussion coming up next. MAID is how we call it. It has a lot of different names, but in Colorado, the most common term for this is medical aid in dying. What is it? It's a law that allows a clinician, a physician, or an advanced practice nurse, like a nurse practitioner now, can prescribe a lethal medication for a patient with a terminal diagnosis who has full mental capacity and the ability to self-administer if they make the request that they want to hasten their death. This has been legal in Colorado since 2016, the end of 2016, so we're approaching 9 years of having this law in our state. It's available in 12 jurisdictions in the US, and that map in the lighter blue shows you, including Hawaii, what other states have this currently as an option. The eligibility criteria include people who are 18 or older or who are Colorado residents. They have to prove that with a driver's license or some other form. They need to be terminally ill with a prognosis, again, of 6 months or less. Once again, I lean on the surprise question when I'm trying to gauge this because it can be tricky to predict where somebody's at with respect to prognosis. And then these last two eligibility criteria are really critical, particularly when we're talking about neurologic conditions. The person has to have the mental wherewithal to be able to make such a decision. In other words, they have to have capacity. They have to also be able to self-administer the medication, which can be hard in some of our conditions that affect swallowing. That being said, they can self-administer rectally with a tube, so they don't necessarily have to rely on swallowing. But these are in general, the key criteria that allows someone to be eligible to take advantage of this law. Briefly, there are 3 visits that are required, 2 with the prescribing provider and 1 with a consultant. The consultant's job is to verify that they agree that the person meets the criteria. And there's a written request where the patient has to sign putting in writing their desire to participate in this program, and that has to be witnessed by 2 individuals. So in my experience, I do get a fair number of people asking about medical aid in dying. Sometimes it's simply curiosity, but a lot of times it's a sign of some sort of distress that we've previously missed. And it's an opportunity and it necessitates exploration. When somebody brings this up in clinic, we've got to get comfortable and recognize we have a lot of exploring to do to sort out why they're making this request, where it's coming from, and how we can help. And we do see a lot of such requests for people living with neurologic conditions. It's not just cancer, it's not just end-stage liver disease or other things. Plenty of requests come in our neurology clinics for this. And so my take-home points, my final slide, are related to palliative care. It's about living as well as possible for as long as possible in the face of a serious illness. At any time, makes sense to involve palliative care, or at least to have a palliative kind of conversation in your typical neurology visit. The concept of total pain, I think, is a helpful concept to think about the various components of living with a chronic disease, not forgetting the spiritual, social, practical sides of living with these conditions like HD. And it's meant to support not just with symptoms, but with coping, future planning, and help with medical decision-making. Hospice, remember, is not just a service, it's also a philosophy. It's this focus on prioritizing comfort when somebody is approaching end of life. And medical aid in dying, again, has been legal in our state for almost 9 years now. And it allows people who are eligible and terminally ill to have a choice in how and when they die with medical assistance. So with that, I think we can save questions to the end because we're going to have a robust Q&A session, and Crispin's coming up to pick up where I left off.
Yeah, so one of my multiple trainings, I'll go through them. I'm certified as a grief yoga instructor. Where do we hold our grief in our body? How do we release it? And certified as a grief educator. So a lot of what it is that I do is around not only what's come, but where it is in our body and what do we do with it. So I'm going to go backwards. I'm Crispin Sargent. I'm the education coordinator with End of Life Options Colorado. We're a small nonprofit. We've just been in existence for about 2.5 years. And we came about because after medical aid in dying was passed in Colorado, there was no follow-up education. So it's been here, but there wasn't community education to both the patients, to their care partners, and I very specifically use care partners because I was doing a session one time and a lady in the back of the room, when I said family, her shoulders came up, and not in a good way. And she said, "I have no family. How dare you?" And she stomped out of the room. So I recognize we're surrounded by our care partners. And of course, I lost my complete train of thought of what it is that I wanted to say. But the point on all of it is in this process of the education and what we're doing in options, and I'll just shorten it with options, education choices necessary because there hadn't been a component in the law that says, how are we going to let people know about it? The people, their care partners, the clinicians, and potential providers in the hospitals, in the facilities where they're living, and all of the people that they're working with. So that's our task. In my background, I had been a private fiduciary. Fiduciary meaning I was responsible for people's money. So I've spent the last 40 years as the medical power of attorney, the financial power of attorney, the trustee, the conservator, ultimately the personal representative, oftentimes working with people that did not have care partners, did not have family, or had dysfunctional family, and they needed an independent third party to serve in that role. So I come into this with my experience as the person sitting next to the person who has said, please speak for me if I can't speak for myself, listening. Because that was my job prior to that point when they couldn't speak for themselves. That was my job, to listen. So the thing that in coming into that, I also got training as an advanced care planner, meaning I help people with the documents, and also got training as an end-of-life doula. Some of you may be familiar with the word doula, birth doulas. I had support at the time of the birth of my child. Before the birth, at the birth, after the birth. And at some point, somebody said, we've got support, non-clinical, support for folks at birth. How about support for folks at death? So the concept was having non-clinical folks in a variety of support. So I have training in that. So I so appreciate following Dr. Vaughn today because she alluded to so many things, but my intention today is to not only provide you with your action plan, but to provide you with some tools so that when you leave here, you've got some things in hand. So one of the things that Dr. Vaughn talked about, and I want to reiterate, are the legal choices of what everybody has a right to do. And this doesn't apply just to those with a particular diagnosis and those of you in this room. It applies to everybody. Everybody has choices. Everybody has a right to make their decisions, and everybody has a responsibility of telling somebody else about what it is that they want to have done, and not only tell them, but write it down. So that combination. So you have a right individually to continue in your care, continue in your clinical trials, continue in your testing, continue potentially in surgery. You have a right at some point to stop treatment. You have a right to hasten your death. You have a condition, it is progressing, and at some point, you have a right to say, wait, I'm going to let it continue naturally. It's going to end when it's going to end, or I'm going to stop and it's going to end when it's going to end, or I potentially have a right to hasten. Dr. Vaughn talked about the law that makes it legal to use medical aid in dying, but what happens if you don't qualify? She indicated the eligibility, have to be 18, have to be a resident of the state, have to have a terminal condition, most importantly, decisional capacity and ability to self-administer. Let's talk a little bit about, and not from a clinical perspective, because I need the clinicians in terms of the clinical perspective on this, but decisional capacity is quote unquote easier in this arena because it doesn't matter if you don't know what day it is. And it doesn't matter if you don't know where you are. It matters if you know your diagnosis, you know the physical condition that you have that makes you eligible. It matters that nobody has talked you into this, that this is your own decision. And it matters that you verbally can indicate what's going to happen when you take the medication. So you have to know how you came to this. You have to know that you're making this decision on your own, and you have to know that when you ingest or administer the medication, what the result is going to be. You have to be able to indicate that you know the result is going to be your death. That's decisional capacity. The self-administration, quite honestly, is thumb dexterity, because you can ingest orally or rectally, but you have to be able to have an ability to connect the plunger, or through a G-tube. A G-tube cannot be inserted to do this, so if you are on a G-tube, then thumb dexterity. So it's all of those things. So going back, what happens if you're not eligible? You don't meet the decisional capacity. You can't self-administer. The other option is VSED. What's VSED? Voluntarily stopping eating and drinking. Now, in a natural process of dying, we're going to lose a desire for food. We're going to lose a need for hydration. That happens naturally, but in VSED, voluntarily stopping eating and drinking, you are making the decision to stop. Not in the natural process, you're making a decision. It is not an easy decision, and it requires support. It's not an easy decision, it requires support, and we come around to the importance of the relationship with your palliative team, your hospice team, to be there for that process. But it's one of the things that says you want to have choices about what it is that you're doing, and it may be that you're not eligible for medical aid in dying, but you are eligible under VSED, voluntarily stopping in the eating and drinking. All of this, in this process, it's always weighing quantity over quality. Quantity is how long is your life going to be. Quality is what is literally, what is my definition of my quality of life? And we define it lines in the sand. I hit this line in the sand. Quality is not what it is that I'm looking for. Therefore, this is what I want assistance, either where I'm verbally giving it or I can't do that anymore and my agent is doing what it is that I've asked. This is my line in the sand. It changes. And that's why it's important in knowing in your advanced care planning how important it is that you can change your mind. And again, Dr. Vaughn said this, you don't have to have an attorney involved in this part of your planning. Rip, rip, rip. You can tear it apart. You can change your mind. The piece that's important, again, you can change your mind about the person that you name to serve as your agent, as your person speaking for you. Not a difficult process to do that. Doesn't require an attorney. Rip, rip, rip. You do the next document. Rip, rip, rip. What are we ripping up? It's the pieces of paper. Let me show you the first present I have for you today. So first one, Compassion and Choices it's a wonderful national advocacy group advocating for passage of law. They provide wonderful, wonderful material. So I brought for everybody today, I've got plenty of them. So if you've got a friend at home, you can take one. This is a wonderful conversation starter because throughout this, if this, then this. If this, then this, and you have an indication in doing your values, what's important to you, and letting it be known. So you complete the document, you sign it, you put it in with your paperwork. It has a dementia addendum in it, specifically on a change in cognitive ability. What do I want if I'm not recognizing people? What do I want if? So there is a specific dementia addendum in here. The other thing that I put in here, three other things, information about End of Life Options Colorado, how to go into our website, a little handout, how to have conversations with your doctors, how you choose, not just your doctors, your clinicians. It may be a physician assistant, it may be a nurse practitioner, how you have conversations about what's important. And then thirdly, there is a sheet of links to resources. I highlighted End of Life Options, also other resources, and below document links, so that in this piece, these are your instructions. Separate document to name your person. So our links in here to just pull off the medical power of attorney, Colorado medical power of attorney that you can complete. So those are presents for everybody that I brought today. Because what's important is not only that you've given what it is that's important, you've talked about it with as many people as you want to, you've written down what it is that you want to have happen, and you've had more than one conversation with the person that you've named as your agent. I mentioned that I've served professionally as a financial power of attorney, a medical power of attorney. And I hate to tell you how many times I've gotten a call at 3 o'clock in the morning from the hospital that somehow has tracked me down and said, I understand you're Mary's medical power of attorney. She's here at the hospital. Can you come over? I've never heard of Mary. I was named on her documents, but I wasn't contacted by the attorney and I wasn't contacted by the person. I have no idea who Mary is. And I'm going over at a time to make decisions for her of what it is that she wants. And I, in a Sherlock Holmes way, the best of my ability, try to figure out what she might want. So the thing that becomes important when you're doing this, have conversations with the people that you've named and make sure you've chosen the right person. It's not always your spouse. Your spouse is not always able to make very difficult decisions at a highly emotional time. So sometimes it's not your spouse. The other day, I heard a woman talking about her documents, and she said, not only in my documents have I named who I want to speak on my behalf, I've specifically named who I don't want. She has 3 children. She said, my two sons know exactly what it is that I want, and they will do it. My daughter will keep me alive forever. I have told her she is specifically not named in my document and specifically doesn't get a vote. And the daughter knows this, and she's kind of relieved the daughter of the responsibility. So she did both, and she did the other thing. She got them all together. They had a conversation, and the daughter's okay. The daughter is relieved that knowing that she will want to do what she wants to do, but she's relieved that the mother has taken care of that. So my conclusion, and then Dr. Vaughn and I will open this up to conversations. Think about your values, think about what's important to you and the decisions that you want to make. Write them down, have a document that names the person that you want to speak for you if you can't speak for yourself. Have another conversation with that person to make sure you've chosen the right person. Complete the dementia addendum and have that in your document. So a shift in your cognitive ability, that you've got that documented. And then be aware of the two things that I didn't talk about today, but that in your just thinking about as we're planting seeds about the things to talk about, think about at the time of your death, what you want to do with your body disposition, and think about what do you want to do with your stuff. So in your thought process, if you're having conversations with an end-of-life doula, you're having your conversations with your care partners, you've got that time from now up until your death, you've got the day of your death, and you've got what happens after your death. And regardless of a medical condition that you now have a known condition that might have a terminal end for you where you can name it. This applies to everybody. This applies to me. It applies to everybody in this room. Everybody needs to have the documents, have the conversations, and live their life in between. So taking charge of and taking care of business, because that's what I'm talking about here. This is the business. This is taking responsibility and then put it someplace where everybody knows where you've put it and live your life to the very best. So Dr. Vaughn, why don't you come on up here and we can be available for questions and what from a non-clinical perspective, I gave you your to-do list, provided you with some tools to complete, and then we can go forth here.
Thank you so much, Crispin and Dr. Vaughn. Round of applause for them as well. Thank you for taking your time today. And our last speaker of the day is going to be the one and only Greg Jarvis, who many of you probably already know. He is a fierce advocate of HD and research, retired from the National Park Service, and he is going to come and just tell us a little bit about our local HD resources, centers of excellence, and what we have to offer here from the local chapter.
What our centers of excellence are, how they're connected to HDSA, and I will try not to get the feedback. And you know who the social worker is, who Beth works for, and how it's all coordinated and put together. But this is our Rocky Mountain chapter board. And you've met Liza and Floyd's in the audience here, helping people out in the parking lot get in here. Ivana's up here in the front. Justin just left, myself. And we have a number of people and some new folks that have just joined. And we have people spread across the state. We have members in Leadville and members in Grand Junction. So if you're not local, you can still be part of us. But our big focus is, you see there in the bottom, to improve lives of everyone affected by Huntington's disease. And these are kind of the key areas that we work on and that we talk about every month that we have a chapter board meeting. Support, how do we build awareness? How do we advocate for people and within the HD community? How do we provide information? And to support all this, how are we going to raise funds? Which is usually a good chunk of our conversations because we have lots and lots of events. In fact, we were just recognized as one of the lead chapters in the country in event organization. And 2 years ago, we were named the chapter of the year here in Colorado. So we have a very active group and we are all volunteers. That's another important thing to realize. And then how we provide research and how we interact at HDSA. And this is kind of how we work with our centers of excellence. And I'll talk a little bit about that on a couple slides. Okay. Providing support. We have our social worker, Beth, that introduced herself. We have support groups. We have Denver Metro group that we have once a month. We have a national gene positive group on behaviors. We have international members that join that one and talk with people. And that's always really interesting to see who and what kind of support people have in other parts of the country and even outside of this country. So it's a very interesting group to be part of and talk. And I do the peer support for those support groups, and Beth leads those also. We have a Grand Junction support group over there, and we have a virtual caregiver support group that meets on a quarterly basis. And we assist and partner with the local centers of excellence in organizing events like this, as well as on a quarterly basis, talking to Dr. Forbes and Dr. Salinas on how to better work our clinics. One of the things that hasn't been brought up is that we have a monthly clinic that's supported by HDSA. Both of these clinics get a grant to operate on a monthly basis for people to come in and talk about and get seen by professionals. And we build awareness. We work with folks in law enforcement service organizations, different university students. We've had people that want to learn about HD. We go out and talk to those people in the community. That's what our social worker does with part of her time. As well as going out to long-term care facilities that are caring for people with HD to work with those staff that might not have that much background in HD and try to educate them, because a lot of times we have people that are in those facilities that are maybe a little bit younger than the typical people that you see there. So it's really nice for our social worker to go out and help that staff learn how to work with somebody with HD. And we have a group that works very cooperatively with the National Youth Alliance. A couple of members of our chapter are on the National Youth Alliance. They just got back this summer from, was it Prague, I believe, for the international folks, young folks. And youth, they classify as anybody like 30-ish and under. So it's not teenagers, although teenagers are included in that group. How we advocate, we work, and I spent a lot of time at one point working on healthcare reform and meeting with legislature folks, getting them to recognize HD, understand what it is, help us out with getting the laws changed within the Social Security, the definition of HD in those, because the old law was one that was very, very old. Those are all those kinds of things that we look at and work on. Healthcare, insurance access also I have up there. And we educate, we do food for thoughts education events. We lead this symposium that we do once a year. We have about 3 or 4 different meetings throughout the year with a lot of the people that you see in this room to kind of talk about what our agenda is. It's very important for you to fill out that survey in front of you, because we will be looking at that. I think we have a meeting on Halloween morning to discuss how this went and what are some of the topics, and start looking for speakers for 2026. So those other things there, I just talked about a little bit. How do we support all this? Because it costs money, of course. In the springtime, we have a celebration of hope where we honor people from the HD community, individuals as well as collective organizations or clinicians or such in the spring. And we also, that is one of our fundraisers where we raise money. We have peaceful poses for HD event, which we did our first one this year, which was a yoga event that was extremely successful. We have our Heroes and Villains 5K Huntington disease walk and race that's over here at Central Park. And we have our Fairways of Hope golf tournament, which has been being held out at Arrowhead Golf Course for the last few years. A big fundraiser, as well as our annual Amarillo sales, which are now kind of moved to almost a fully online. But I'll put a plug in for them. The Amarillos I got last year was the best I've had in years, but they went to a new company. So they're very nice now. They all bloom and rebloom. We're social now. You can find us as always on the Rocky Mountain. Just type in Rocky Mountain chapter or HDSA, Colorado. We got it listed so that it falls out, even though we're the Rocky Mountain chapter. We're based in Colorado, so no matter which item you search, you will find our page for HDSA. We're on Facebook. You can join us there. And just here recently, we are now on Instagram. And here's my plug to get more folks, because you never know who's going to show up here. But you can participate in the fundraising events. You can volunteer to be part of a committee. Not even, not be a chapter member, but just, I want to help out with the run. I want to help out. One of the events I had, forgot about it on that list, is I want to help out with Drag Queen Bingo next year, because that's going to be one of our events. There's all kinds of things you can do. You can attend a support group. They're all online now for the most part. Be an advocate. Speak to a group. You can join the board. And then, as always, there's those opportunities here at the year end, the giving days, and those kinds of things that are coming up that you can give your financial support if you want to do that. Our centers of excellence, that's who's helping us host this event, both Dr. Salinas' office as well as Dr. Forbes' office. They do get grants on a yearly basis. I put together a letter of support for those groups, and it gets sent into our national organization, and then they help fund some of the things that they do. We have two of them here in Colorado. The only other major metro area that has two is Chicago. We have fought hard to have those two here. They kind of cover different areas. We have one of the first ones that were ever established at Dr. Salinas at the Rocky Mountain Movement Disorders Center over by Swedish. It was one of the first ones that was established over 20 years ago, even prior to Dr. Kumar. Lots of you guys probably know him. And the University of Colorado has now been around probably for about 15 years. And they have different roles, and they have different types of research opportunities. And they have these monthly clinics. Please be sure to talk to them if you aren't a part of that and want to be part of that. There's genetic testing available at both of these clinics using the HDSA protocol, which gives you a team of people to help advise you and move through genetic testing. And there's these educational opportunities that they help us out with and are responsible to helping us out with. And then one of my big things is I've been involved in probably about 15 different research studies over the last 20 years I was originally involved in the predecessor to enroll, which was the Pharaoh study, before I got tested. Afterwards, they had Predict HD, which have now been rolled into the Enroll study. But being involved in these research opportunities, it's just amazing. Here in Colorado, we have some of the largest enrollments globally in these studies. The Unicure study, a lot of folks have come through here, through Colorado, to be involved in that. And there wasn't a whole lot of people in that study. I think 29 I counted when you added the low dose and high dose up. But a lot of those folks came through here in Colorado. And that's because of the system that we have worked up here, 2 centers of excellence. And one of my things is being a part of the research study. I can't advocate for you to be part of a research study because, you know, the more data points, the better for all. And I've been contributing those data points since 2003. So if you can be involved in these studies, even if you're not a person directly affected by it. My daughter participates. She came in with me and saw Liza on our last enroll visit, and she tested negative for HD, but is a control subject. You can be involved that way.